You're listening to Healthcare Now Radio. Stand by for This Just In, the latest in healthcare innovation and technology trends with your HIT advisor, Justin Barnes.
Thank you for joining me today on This Just In Radio. I had an amazing time this year at the HIMSS annual conference as we aired This Just In Radio live from the show floor. Our fourth year in a row, and thankfully, they always get better. Thank you very much to all of my amazing guests that came by to share their time and thought leadership. Many thanks to the show sponsor, Lenovo Health, and certainly many thanks to Roberta Mullins and the Healthcare Now Radio team for producing this show. We've compiled all of the guest interviews to share with you in this broadcast, but look for many more in the coming weeks. You'll also find these interviews on our archive channels. Just check in at thisjustinradio.com. We hope you enjoy these HIMSS18 recordings as they are all in their true environment with 40,000 healthcare and health IT leaders all around us, as this year we placed our studio right in the middle of all the action. And you'll be able to hear the energy and hopefully feel it as well. Enjoy.
I appreciate you being here. So Genevieve Morris, Physical Safety News Reporting for Health IT, ONC, and I guess HHS. I always say ONC, HHS. But so thank you, first of all, thank you very much for joining the think tank this morning, being live on air with us here. So I guess maybe a very similar talk. Your talk this morning was fantastic, and I know that you've lost your voice a little bit. You're getting it back. I was warned a couple of days ago, I think by Dr. Jamie Skipper, said that your voice was a little under the weather.
I at least don't sound like Mark Simpson anymore, so that's a plus. But,
That's great. So what did happen really quick?
I had a little bit of a vocal cord injury.
Okay.
So I'm slowly recovering.
You're from your American Idol tour?
Yeah.
Excellent. Well, so give us a little bit. So this is, your talk this morning was fantastic. You had a little bit of an ONC policy update and a little bit of a TEFCA update.
Yeah.
So I would love, the floor is yours. That's fantastic.
So I think, start with a couple of the more innovative things that ONC is doing. And so from an innovation perspective, there's a couple of projects that we have underway. One is around something called flat fire, whatever you want to call it. We call it population level data. But it's basically the concept of, when FHIR was created, it was for individuals or physicians or patients to access their data using a FHIR API, which is a great use. But you may want to also do other things with those FHIR APIs, like have servers automatically ask for data on the app, and maybe pull that data together so you can do some local analytics.
Excellent.
So in order to do that, we are working with HL7 and the Smart on FHIR folks and a few other folks to build out something called flat FHIR, which would allow backend servers, all under, of course, the requirements of HIPAA, to be able to pull population level data, so 500,000, 600,000 thousands of patients all at one time. So you can pull either into your data warehouse or your data lake, whichever you prefer, and do the analysis you want to do. So that project is ongoing. I think we actually are expecting to have a first version of that spec maybe later this year or early next year. So that's exciting work. We also have a project with payers and providers called P2, which is a task force. The payers sort of understood there's some new ways that we can get clinical data to do the things we need to do. And we want to do that perhaps without having to build 20 million interfaces that are often built. And so they're really excited about some of the potential uses of FHIR, and they want to actually roll some things out in real time, or not real time, but roll things out faster than perhaps they're used to. And so they asked us to be the task force for them so that they as payers can work together and come to agreement on some use cases. So that maybe, since physicians work with multiple payers and they're all using the same FHIR API, it becomes easier for those physicians to connect. So we have those things going on. Those are the more innovative things. And then we have the Trusted Exchange Framework and Common Agreement, which, again, depending on your opinion, innovative, not innovative, you can't say it's...
It's great foundational work that we do as a country.
It is, correct. And, there's all the really cool, sexy stuff everyone wants to do, and there's just, the hard grunt work stuff. I personally prefer the hard grunt work stuff. I think it's important to getting us where we need to go, so that's what I focus my time on. And so what you can say about the Trust Exchange Framework is it's not the status quo. I think Congress sort of made very clear that we are not happy with the status quo. It is not working for physicians and for patients, primarily. It might be working for some folks. It's not working for a lot of folks. So in the Trust Exchange Framework, what we're trying to do is enable health information networks to connect to each other, to be able to share information both for physicians, for individuals, for long-term care, behavioral health, and community and social services. Not all of that is day one stuff. Obviously, you have to build over time. But we think that this will move us forward on interoperability. So we focused in on some of the principles, guardrails for exchange, as well as some of the minimum terms and conditions where folks just have to agree or you're not going to have exchange. So the draft was released in January. We got 220 comments, which I'm almost done reading. Not going out to go and see, but I am at least. And we're working through those to try and figure out, what our next steps are.
Excellent.
I'll let you ask some questions.
Yeah, no, this is fantastic, because also, it's a great question. I'll give the plug to Lee Rochelle, our friend from All's Group. She has a great question around some of the themes. I know that you're still you're still reviewing all the comments, but maybe 5 minutes or so on the themes that you're seeing
Sure.
part of these comments.
And I will note for everyone that all of the comments are posted publicly up on our website, so we're going to post out a link to it in probably tomorrow's ONC newsletter. I will try to remember to tweet it out today if I have a spare second.
Yep.
But they are up on our website, so you can read all 220 comments. So a couple of the things we've heard, by and large, everyone was very supportive of having a recognized coordinating entity, which is an industry-based, most likely not-for-profit, non-profit organization that has operationalized this.
Yep.
Everyone agreed. ONC probably isn't the right group to do that. It's fine. Folks disagreed a little bit on how much authority they should have, but everyone sort of understands the need to have a neutral convener who has broad stakeholder engagement from across all the care continuum, including we also heard from folks sort of two flavors that you were too aggressive.
Right.
One was on timelines for implementing standards, which fair comments. Folks know ONC well enough to know we're always a little optimistic, perhaps.
Well, you're also trying to push the industry forward a little bit too.
Correct, right? I mean, I think we want to signal to the industry where we're going.
Yeah.
And so we heard that comment. And then the sort of the second flavor of too aggressive is you're asking us to do too much too quickly. You got to crawl before you walk, before you run. And to that, I would say we've been crawling for many, many years.
Yeah.
We need to walk.
I call it dragging the anchor. I was just talking about that at dinner last night. It's like we're just dragging the anchor.
We have, right? And like this thing, I worked on the interoperability roadmap, and we heard the same thing, right? Like you're trying to move too quickly.
Right.
And at some juncture, we just have to accept that we have to make a decision and move the ball forward and not continue to kick the can down the road.
Yep.
Because it's never going to come, right? So we want to, we want to move past the status quo. We want to be reasonable, but we also want to stretch. And so, we want to try and work with folks to figure out what some of that happy middle ground will be. Guaranteed, 50% of people will be unhappy with both. So we heard those comments, and then we did also hear a lot of, moving goods over to implementation guides, very fair comments, standards change rapidly. And again, that's finding the right balance between what you put in an implementation guide versus what you put in an agreement.
Right.
So, we're working through things like identity grouping levels. Does that go in an implementation guide? Does that go in an agreement? There's some gray areas that we really have to think through carefully. But overall, I think folks agree with the world we're trying to create and with our goals. It is really easy to agree with goals. It's very hard to agree with how you get to it.
Very true. That's welcome to Capitol Hill in a lot of ways. That's right. No, well, you guys are doing a great job. So, what interoperability advancements should we expect by doing some of this laborious work and the grunt work that we can do as a country? What's the end result? What should we expect the next 2 or 3 years from some of this work?
Hopefully, in the next 2 or 3 years, we'll have a couple of things. We proposed this concept of a single on-ramp to interoperability in the trust and change framework. And, we didn't mean a literal single on-ramp. We meant figurative, right? So what I'd like to see in the next 2 to 3 years is if I'm a physician or a patient or a long-term care facility, I really only want to maybe join one network. I might want to join multiple, right? So to give the example, I have a work phone and I have a personal phone because I work for the government. 2 different networks, right? That's okay. They're 2 totally different purposes. I would actually really prefer if I could just have one phone and one network. I'm just going to say that.
Yes.
Obviously, that's not legal. So that's cool.
Of course.
But I think a lot of folks want that network capability where if I want to work with 5 different people, I don't want to build 5 different interfaces or join 5 different networks. I might just want to join one. And so trying to figure out how we get to a place where folks can offer different services, but maybe not make me join all of them. I think that's hopefully some of what we're getting to. I think on the patient and individual access side of things, with the Fire APIs and with some of the companies out there who are the big names who I won't mention, but who are the consumer type of products, I think we're going to see them taking advantage of the Fire APIs and trying to figure out how to get data to the consumers more easily. Now, one thing I think we have to think about is we still have a many-to-many problem.
Yes, we do.
And every provider is their own Fire endpoint. And I think we need to be very, very smart about how we facilitate that so that we don't end up with the same exact issues we had when Direct was rolled out, which Direct was solved, how interfaces were rolled out. I think we need to be smart about that, and we're definitely, from an ONC perspective, talking with a number of other countries who are starting with Fire APIs as their first connectivity piece to figure out how they're using network capabilities to enable access. So I think in the next 2 to 3 years, I'm very hopeful that we're going to start to see a market who understands that we should not be competing with data.
Right.
That the data should be freed up, and you should figure out how to make your money on offering better services. And I'm a broken record on this.
Yep.
Every other industry has done it. So why can't we?
Right. I completely agree. So in our closing 38 seconds or so. Now, can you give us a quick glimpse of what you see from this administration? You gave a couple of just great points this morning, so maybe what we can look forward to for this administration on the health policy side.
Yeah, so we have a couple, from an ONC perspective, we have a couple of things rolling out. We have the regulations certainly that we're working on for cures that include information blocking exception, conditions certifications, and things around the trust framework that will be out in spring 2018. With the announcement from CMS yesterday on Blue 2.0 and high healthy data, which I did say at the beginning, gets you theoretically discrete access to EOB data, which I actually think could be quite powerful if you can figure out how to operationalize it.
Right.
I think there's going to be some innovative folks who figure out how to do that.
For sure.
So there's
and I'll have Anish Chopra who's going to talk a lot about that later on.
Excellent.
Yeah.
Excellent. And then some other things is, we are looking to rethink moving pages and KPIs and restructure around interoperability. We're working very closely with CMS around that. I think as we think about restructuring around interoperability, we're also trying to figure out how we can restructure some of those measures to take advantage of health IT rather than making physicians check another box. How do you make use of some of the automated features that will measure some way? Thinking around clinical quality measures, so we're thinking around that. And then just from a more general perspective, Secretary Azar spoke to the Federation of American Hospitals on Monday.
Today's Wednesday, I guess, yeah.
And he said, at the end of the day, I'm actually all for pragmatic incrementalism, but sometimes you have to make leaps.
Right.
And I think we're at the point of making a leap, and his point was sometimes that means people are going to be disrupted. And not all disruption is bad.
And that's okay.
Some disruption is good.
That's right.
And I understand that means that some businesses won't exist in 2 to 3 years. I think we have to be less afraid of disrupting businesses that are not providing value and more afraid of the fact that we have massive patient safety issues because data is not being shared. But at the end of the day, I care because it's very personal for me.
I agree.
About getting data where it needs to be when it needs to be there so that we can care for our citizens.
That's fantastic. I love it. Thank you very much. I will say, you have a great collaborator in your office, Stephen Posnack.
Yes.
He's
Dr. Posnack.
Yes.
He's affectionately known.
Yes, he's amazing. He's been phenomenal.
Fantastic.
Working for about 10 years now. I love him. Great guy.
I've worked with ONC for 6 years as a contractor before this, and all of the team is fantastic, incredibly hardworking, very, very thoughtful. And at the end of the day, we all want to do what's best for the American public.
So true.
It doesn't mean we're always going to get it right, but that is our goal, and it's great to work with a group of people who all feel that same thing.
Genevieve Moore, thank you very much for joining the show. Thank you. Excellent. All right, Dr. Skipper, you're next. So thank you very much, Dr. Jamie Skipper, CEO of Elevation Health, and also former ONC research scientist.
Absolutely.
And a long-term friend. You and I, we worked together on Capitol Hill for, 10, 12 years now.
Yeah.
You were with Dr. Gingrey's office, and that's when I first met you, but you've been a great collaborator, so thank you very much.
Yeah, it was a great time back then. Watching high tech just come into play, it was few years right before iTech got passed. So yeah. Closer. Okay.
Perfect. There you go.
Got it.
Because actually, yeah, the radio microphone's picking up perfectly with the mouse, so everybody hear you. But then also, thank you for being a great collaborator in the think tank. You have been a great addition. You've been there since day one. You've been at all 3 think tanks, and you've just been a great helper there. So thank you.
Yeah, it was really great to be part of that. Thanks for letting me join in, and we had some great conversations.
Yeah, we'll be publishing a lot of that out. So everybody online listening, you'll be seeing the think tank. I know HIMSS is publishing some stuff, but Health Data Management is going to be doing a lot more in the coming weeks, and publishing some great content. Diana, look for some stories by Diana Manos for sure on the think tank. But let's dive in. So, what healthcare or health IT trends are you seeing out in the industry now?
So I've been looking at it from the DC lens for a number of years. So I was at ONC for 7 years now, and just last year
I've known you for, at least 12 years.
Long, yeah.
Too long.
Too long.
Great.
Not as long as you've known Elaine, but
Lee, right? Yes. Well, yeah, I was beginning to tell you. Let me say 30 plus years. But yeah, exactly.
Yeah, but no. So I've been working at ONC for a number of years, listening to the trends from maybe my vantage point. So when you talk to different people about what they're seeing in the health IT span,
sure, yeah.
I mean, there's so many things you can name, but from my point of view, so at ONC, I was really looking at how to build data infrastructure to liquidate data, of course, with the privacy controls and protecting data, but trying to get the data accessible for researchers to really look at the data and think about precision medicine and think about health outcomes, making sure that when I go to the doctor, I'm getting the best care. And that's not just based on altruistic motives, it has to be based on data. So how can we get the data out there? So back to your question about the trends that I'm seeing, I think it's really exciting to see more data liquidity at least being talked about.
Yes.
I think it's really nice that just walking in this amazing zoo of
44,000 people and 1,200 exhibitors or whatever.
Absolutely. And I just am overwhelmed by how many people are in this together to try to figure this out. And so we're still really are working on interoperability, and that's one of the trends that everyone is talking about.
Yes,
finally, right? I think the trust exchange framework is going to be really key. I think just the nuts and bolts of getting the data out there and really listening to a lot of folks, even the other day, from Google, Eric talking about using standards and getting geeky and talking about FHIR and Smart on FHIR was just, it was just amazing.
Eric Schmidt, founder or chairman of Google.
Absolutely. Yes. Mm-hmm. And then I think that it's really awesome to continue to see the patient voice grow and grow. And, it started a number of years ago just getting a real good home. I think the patient-centered outcome research folks really, really changed the game, especially in the research side, to make sure, being a researcher myself working at NIH, it was amazing to see PCORI come in and say, we're not going to fund you unless you have patients on your panels designing the research, making sure the information that's coming out is actually meaningful to the people that it's going to be used for. So those are the trends that I'm seeing, liquidity, interoperability, and really putting that patient in the center. And what I'd love to see in the future is even more designing from the ground up, putting the patient in the front.
So that's fantastic. So tell me, what are some of the best practices or guidance you would give people to begin to deploy or move in that direction to jump into the opportunity there with best practices that we just talked about?
Yeah, so, it's definitely a give and take. I was just talking to folks from Lenovo about, the tension and in terms of, you when you're a small business, and now I am one now too. So, just started Elevation Health Consulting, being that startup. You're trying to feed your family. You're trying to pay bills, and so trying to get the sale out there, getting the clients. That's just fundamental to just staying alive. And so trying to get folks like that to be able to step back and say, when I design from the beginning, why am I designing this? What am I doing? There's a famous speaker, Simon Sinek, that always tells folks to go back.
Simon's amazing.
He's amazing.
He's amazing. I'll tell my audience right now, you need to go check out Simon Sinek, and a couple of his videos are on YouTube.
Absolutely. He says there's three things. There's the why, there's the how, and there's the what. And a lot of times folks, especially, in our field, they've got the what, and then they're trying to say, how can I use the what for the how? And then they try to kind of layer in the why because they've got the stuff already designed. But if we can start with the why, then we can really address a lot of the things that we're dealing with. On the research side of things, I really love what Picori is doing in terms of saying, we're doing research for the patient. So let's ask the patient what we need to research, and we need to figure out how that data is going to be used. And how are the researchers that are going to ask those questions really get the data that matters to doing the research that matters to the patient. So that means, how are we going to get data from the clinical space? How are we going to get the data from the payers? And then how are we going to get the data from the patients, the patient-reported outcomes that are, Genevieve said earlier today that 80% of care is done outside of the hospital.
Yes, 80% on the ambulatory side, yeah.
It's on the ambulatory side, which is your background, right?
My background, yeah.
Absolutely.
I started in the acute, now into ambulatory. Yeah.
You got a big background.
Yeah, exactly.
What are you?
I'm not old, though.
So figuring out how to take all of this data, get access to that data, and then make sense of it, bringing it all into one place, aggregating it, normalizing it, and then making it usable. But here's the key, doing all of that in a way that's actually affordable, because there's capabilities and then there's affordable capabilities, and that's really the tension there.
Oh, that's excellent. So in a closing minute or so, what else do you hope to see and achieve while at HIMSS18?
Yeah, so one of the things that I really want to highlight, if you haven't had the chance to check it out yet, is some of the things that the VA and DoD and NCI are doing on Elevation Health Consulting's webpage, which is elevationhealthconsulting.com.
You just launched it. The website's fantastic, by the way.
Oh, thank you.
I checked it out a couple days ago.
Oh, wonderful. And, check it out, give feedback. So we just, along with the website, we released a blog with NCI talking about this program that came out of the moonshot called the Apollo program. It is spectacular. It's exactly where we should be trying to go, where they're taking not just genetic data, but proteomic data, and then making it available for developers to say, hey, we've got all of this data. Come take this data, try to figure out how to make this more usable and create apps and services that are going to make cancer care better. And so please come check out that blog and take advantage, if you're definitely a developer, to take advantage of those tools that NCI has put out.
Thank you, Jamie. Dr. Jamie Skipper, love what you're doing. Thank you so much. And thank you so much for all your collaboration through the years. Appreciate it.
Thank you.
Excellent.
Thank you again for joining me for this aired recording from HIMSS18 live in Las Vegas. And please tune in weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific to always hear our latest shows. As always, you can track me on Twitter at HIT Advisor and use the hashtag ThisJustinRadio so you can respond to your comments from the show. If you miss any of this episode or want to hear more, all of my radio shows are posted at thisjustinradio.com, as well as on Apple iTunes, SoundCloud, iHeartRadio, Spreaker, Google Play, and TuneIn. Also, check out the new website we've launched at justinbarnes.com. Thanks, everyone. Have a terrific week.